Dr. Shupek, we have a 30-year-old woman with a known suprasellar tumor or mass, and I'm here with an experienced neurosurgeon, the big kahuna. Let's talk about the big kahuna briefly, which is macroadenoma. We're not in the pituitary gland, we're suprasellar, so we can get rid of that one and talk about the other components of the big five. We're hunting in Africa together: leopard, lion, elephant, Cape buffalo, and rhino. We've got macroadenoma, it's not. Meningioma, it's not. Saccular aneurysm, wrong signal. No pulsation mismapping, it's not. Pilocytic astrocytoma, that's a possibility. Could it be coming from the hypothalamic region? Although there is a plane of separation right here, and this solid mass in the suprasellar region, cranio, the fifth one of the big five, is likely. And if it is a cranio, it's going to be the solid papillary variety of cranio. And you've seen in a younger individual in an accompanying vignette the adamantinomatous form of cranio, which is more cystic. So this one is solid. If it is a cranio, it's likely to be papillary. What is it?
Right. Well, we've been focusing earlier on the initial diagnosis, but if you're going to do SELA, I think one of your most common indications for ordering a SELA study is not initial diagnosis, but they've been treated and they want to know how they did.
Sure.
How's this patient doing? And this one is kind of a treasure trove of treatment.
How's she doing?
Well, let's look at a couple things here. So we got shunt apparatus here. And in fact, you got two shunt tubes. So why are there two shunt tubes? Well, they're working.
Two is better than one.
Well, no. If there was only if it was working, there'd only be one.
Okay.
So
all right. That's not a good sign.
You got one that's kind of over in the thalamus,
Mm-hmm.
and so the tip is there. Now, there might still be some holes out here, but probably was not working quite as well as it needed to.
Mind if I put a little dot on the tip right over here,
Right.
just so everybody can see it?
Right.
There. There's the tip of one of the shunts in the wrong place. Hang on, let me just close that out for you. Go ahead.
Okay, so we got another shunt tube. Now, this is heading for the frontal horn, so that's in a little better position, although it's kind of, so that's probably got holes exposed, so that may be working, but
Could you point to that shunt in the axial?
right there, okay.
Cross-reference it.
And so here it's the
Okay.
tube coming right up here.
Gotcha.
Okay, and so, but there's an asymmetry here. So it may very well be that this is getting drained more than this, so I'd have to keep an eye on this one, make sure this ventricle is not getting trapped.
Okay.
Okay? So that's one thing to talk about, is how is our shunt working?
Sure.
Now, another issue is, so this was treated, and we've already talked about some approaches, but what's this action up here? Okay? Was this a shunt tube that was put in? And I think the answer to that is no. I think what happened here is there's a craniotomy over here, and then there's an area of encephalomalacia leading to where? To the ventricle. So there was a transfrontal approach to the ventricle taken to try to remove as much of this lesion as possible.
Looks like they hollowed out a little bit right in the middle. If you
Maybe
just
they did.
Put your arrow right over there.
But it's kind of in the third ventricle. It's going to be very hard to reach by this approach, so I don't know how successful it was. Now, there's actually two approaches you could take to the ventricle. One is this transfrontal, okay, which is what happened here. The other would be transcallosal, which actually might have given you a little better shot at this tumor. So you can see they didn't get it out. Now, I don't know, maybe there was some here before. So this is another approach to add. We talked about the pterional approach. We talked about the transphenoidal approach.
Yeah, pterional from the side, transphenoidal from underneath.
So this is an option, transventricular. Now, you need dilated ventricles to do this approach, so they probably were dilated at some point, okay, to give you some room.
That's why they shunted them.
Right. So, but at any rate, there's a bit of tumor left, but, they got some kind of decompression of hydrocephalus, although once again, I think the fact that there is differential drainage is something we might want to keep an eye on, make sure this is not bigger next time we look at it, and suggest that it should be looked at to make sure that this lateral ventricle, which is not getting trapped. And they say there's a transfrontal. So they're going to want to know, how did they do? Well, we got to know what it looked like beforehand, but they probably removed some, but they do have decompression, at least of the ventricular system, and there's no transependymal spread. Okay, so there's been some treatment here that's at least been effective.
Sure. Getting the old scan, as usual, is critical. The optic apparatus is spared. I'm going to ask you one silly question and then make 2 points. And I know it might be silly. When you go transcallosal, do you actually have to cut the callosum?
Absolutely.
You do?
You do, yeah. And you can do that in the anterior portion. You can make about a 1 centimeter. It's right at It's very similar, sort of right at the coronal suture, a craniotomy, and the midline. Now, the thing about the midline is it's actually a great approach. It gives you great exposure, but the problem is the anterior cerebrals, okay? So if you're thinking about something like this, where they might be thinking about a transcallosal approach, really be conscious of where are the anterior cerebrals, because that's the biggest complication of it. Because if you have an azygous anterior
A
cerebral,
single anterior
they can damage
cerebral
it,
artery.
okay, because they can't mobilize it.
Sure.
So if they're looking for two of them, they're going to try to spread them or move them over out of the way so they don't damage that. So if you think that it's something that for a transcallosal approach, really looking for the configuration and location of the anterior cerebral is going to be really essential to the surgeon.
Sure, and it might be prudent to do an MRA to help you out with the vascular anatomy. Two quick points. In the coronal projection, it's rather surprising. It's actually not that surprising. It's mildly surprising that this papillary craniopharyngioma has very scant, little enhancement on contrast-enhanced coronal MRI. You see the nice tapering, by the way, of the pituitary stalk, a little chubbier at the top, thin at the bottom. And then in the axial projection, you can see the lesion is pretty solid, as most papillary craniopharyngiomas are, in contrast to the adamantinomatous variety. And then finally, when you look at the diffusion image, there's no diffusion restriction, and you wouldn't expect there to be in a lesion like this. So that concludes our discussion of this post-surgical papillary craniopharyngioma. Ready to move on to the next case?
Right.
All right, let's go.